Chapter 8 Assessments. We know that an assessment is our first step of our nursing process. The nurse needs to organize and analyze the data to identify the needs and problems and establish priorities for your client's care. In your psychiatric mental health nursing, data collection is also referred to as the psychosocial assessment, which includes the mental status exam. The purpose of the psychosocial assessment is to construct a picture of your client's current emotional state, their mental capacity, and their behavioral function. The data are examined for cues, that is, data that require action. The assessment is also to help us identify the clinical baseline, which is used to evaluate the effectiveness of the treatments and actions or to measure the client's progress. And that's from the American Nurses Association. So, our key terms for this chapter are defined here. They're also found in your book. Again, these are not the key terms, or at least not all of these are the key terms that you need for your chapter 1 unit test, or I'm sorry, for your first unit test. These are the chapter learning objectives, which you can find in the text. These are the nursing concepts that are listed within the text. So, our psychosocial assessment, a nursing assessment in the mental health has the same purpose as for our patients when they're medical. It's going to give us a true understanding of how your client is responding to their illness. However, with our mental health, we need to assess different things, and much of what we're assessing is going to be subjective. We may ask the client questions about the client's emotional state, take some inventory of their mental capacity, and overall try to get a picture of the client's current emotional state, mental capacity, behavioral function. The need for accurate assessment is the same, right? It's the first step of the nursing process, and it's going to be the basis for us developing the plan of care. And knowing a client's baseline is helpful to evaluate the effectiveness of the treatment and measure their progress. Many factors can influence the accuracy and the ability to do a good assessment. The biggest thing is the client needs to be able to participate, and anything that hinders the client's ability to participate can provide us with an incomplete or a vague assessment. Some of the things that can inhibit would be the client's health status, right? If they're too tired to participate or they're too anxious to focus on the information, then they might not provide us with useful, complete assessment. The client might need to be medicated or rest prior to completing this assessment. If the client has misconceptions, right? If they've had bad experiences before in the past, then their likelihood that they're going to want to open up and give information is going to have some hesitancy to it and might make them resistant to interacting. Their ability to understand, right? If a patient has some type of cognitive barrier, then you might need to bring the family in more. If it's something like a language barrier, you're going to need to get an interpreter. If it's a sense loss, such as hearing or vision, you're going to need to identify that and then implement whatever strategies necessary so that the patient's able to understand. Remember, depending on what their level of education is, you might need to change up the vocabulary you use. And also, the nurse's attitude and approach can influence this. If you're rushing the interview, the client might not be inclined to open up. If you're coming in with preconceived judgments or biases, the client might also sense that and then not be willing to participate as well. So the interview, we kind of talked about this over in our therapeutic communications. We know that the environment needs to be safe. It should be private. However, it needs to be safe for you. Again, if you have a client who's sexually preoccupied, being in a bedroom or in their patient room might not be the safest way. You might need to go to a quiet area in the day room. Input from family and friends. This is sometimes called collateral. This gives an idea of how other people are perceiving. Sometimes, if the patient's in the middle of a psychotic break, they might not be able to give permission, and it might be necessary to talk to the patients. Same thing if the patient's demented or having cognitive impairments. Um, if the patient or client is able to give permission, you want to make sure that you get that permission from them. Sometimes including the family can make the client feel more comfortable. Sometimes it may make the client feel uncomfortable. They might not feel as inclined to open up in front of their family. If we're concerned about possible abuse, we want to make sure that we're conducting that in an area away from the abuser, so that way the client is more inclined to open up about it. And again, as we talked about in our therapeutic communication lecture, we want to use open-ended questions that'll help the client open up. And then we want to make sure that we're focusing on what they want to focus on. When interviewing a client, the nurse should select an area that is quiet and isolated from others. True or false? This is actually a false. The nurse should interview a client in an environment that's comfortable and private, but we want to make sure that it's safe for both the client and the nurse. It should be quiet with few distractions. However, it should not be isolated. So the term isolated here is what makes this a false statement. The components, we're going to go over these in the next few slides. This is everything that should be included if you're doing a thorough psychosocial assessment on a patient. So when we talk about history, history involves their stated age, their developmental stage, any cultural considerations, any spiritual beliefs, the history of their present illness, any past medical histories, any allergies, suicidal intentions, homicidal intentions, and things like that. Your general appearance, what's their hygiene like, right? Are they appropriate? Is there 4 inches of snow outside and they're in shorts and flip-flops, right? That would not be appropriately dressed. What's their posture? Are they slouched over? Are they guarded? Or are they sitting upright and attentive? Are they making eye contact with you? Is it appropriate eye contact? Is it too much eye contact? Is their facial expression matching what they're saying? Some specific terms here for these unusual movements. Um, automatisms, which I'm not probably saying that correctly, but these are repeated purposeless movements that have no purpose. They could be drumming your fingers, twisting your hair, tapping your foot. Psychomotor retardation is very slowed movements. Waxy flexibility is when you can put a patient in a position and they stay that way. It's usually awkward or uncomfortable. Um, and then when we talk about speech, is the patient's speech clear? Are they talking nonstop? Are they making sense? Are they just using minimal response of yes or no? Are they using um, neologisms? And these are words that only have meaning to the client. They're saying it over and over, and you're like, what does that mean? Only they're going to know what it means. When we talk about mood and affect, mood is the client's emotional state. Affect is the outward expression of this emotional state. Normally, they're consistent and they match. Sometimes they're inconsistent and they don't match, such as the patient saying, I'm so sad, and yet they're sitting there giggling away. Different types of affect. We can have a blunted affect, which is going to show little or slow response in facial expression. So there is a response, but it's slow. A broad affect is going to display a full range of emotional expressions. A flat affect is going to show no facial expressions. Inappropriate affect is going to display a facial expressions that's incongruent with the mood. It's often silly, giggly, regardless of the circumstances. So that inappropriate affect is going to be that giggling patient that says they're sad. Restricted affect is going to be displaying one type of expression. It's usually going to be serious or somber, so serious or sad. And the client's mood, um, so labile is going to be when their mood's going to change rapidly. So rapid mood swings. 1 second they're crying and sad, and the next they're euphoric and happy. And these rapid changes is going to be due to no apparent stimuli. So it's not like they're watching a video and 1 second, they're crying and the next second they're laughing and there's some type of stimuli that's making it happen. This is going to be a rapid change in response to nothing. That's going to be your labile mood. Our thought processing content. So, the process is how the client thinks, and the content is what the client is thinking. There's different um, so when we talk about circumstantial thinking, this is going to be the client eventually answers the question, but only after giving excessive, unnecessary details. So you're going to ask him, how do you feel today? And they're going to go on about maybe a movie they saw last night and about dinner 3 weeks ago. And eventually they're going to get around to answering your question. So they're making a circle around. Delusions are false fixed beliefs. They're not based in reality. Some delusions can seem very real, and if a patient is very convicted to their delusions or very consumed with them, they can actually get you to believe in their delusions. I go back to when my brother was in his psychotic break, and his delusions was that his wife was cheating on him. It was a false fixed belief, but if you did not know his true reality, then you were not aware that this was a delusion. Flight of ideas is going to be an excessive amount of information. It's going to be a rapid rate of speech, and it's going to be composed of fragmented or unrelated ideas. Um, your ideas of reference are going to be clients' inaccurate interpretation of general events, such as hearing a speech on the news and believing that the message had a personal um, message for them. Your loose associations are going to be disorganized thinking that jumps from one idea to another with little or no evident relationship between the thoughts. Tangential thinking is wandering off topic and never providing the information requested. Thought blocking is when a client's going to just stop abruptly in the middle of a sentence or a train of thought. Um, this is thought sometimes to be a defense tactic of the brain because of what they're getting into is something that's going to be hurtful to them. So the brain stops them from actually getting to that end of that. That's just one theory behind thought blocking. Thought broadcasting is a delusional belief that others can hear and know what the client is thinking. So thought casting and thought broadcasting kind of borderlines on your paranoid delusions that everybody can hear what I'm saying. Thought insertion is a delusional behavior that others are putting ideas and thoughts into the client's head. So, I'm getting, the president made a speech and he's putting these ideas in my head. Thought withdrawal is a delusional belief that others are talking the client's thoughts away, and then the client's powerless to stop it. And then word salad is just unconnected words. They don't mean anything. And if you ever have somebody who does a true word salad in front of you, it's very bizarre. Sensorium and intellectual process. When we're measuring this is going to be the client's orientation. Orientation is going to refer to a person, place, time, and sometimes the situation. You're going to have to ascertain this information from the client. Remember that disorientation is not synonymous with confusion. A confused person cannot make sense of their surroundings or figure things out, even though they might be fully oriented. So you can be oriented to time, place, and person and also be confused. Memory is going to, with the nurse, to assess memory, we usually want to do both recent and remote memory. So with our recent memory, we might ask a patient to remember 3 or 4 words. And then for our remote, we'll ask them what they did for their birthday last year. And then after they did tell you what they did for the birthday, then you'll go back and ask them to tell you those 3 or 4 words again. And that'll tell you if they have both their recent and remote memory intact. When we talk about abnormal sensory experiences or misconception, we're trying to figure out if the patient can concentrate. So if your client's able to concentrate, we can have them spell the word world backward. Sometimes we can have them do subtracting serial sevens. So you'll have them start at 100 and subtract 7 and subtract 7 again and 7 again. When we're doing abstract thinking and intellectual abilities, we can have the person, we can tell the patient a proverb, like a stitch in time saves nine. And the abstract meaning of this, if you take time to fix something now, you'll avoid a bigger problem in the future. The very literal translation of that is don't forget to sew up holes in your clothes, right? So, does your patient have the ability to abstract think and use intellectual abilities, or are they going to take it very literally? Sensory perceptual alterations are going to be your hallucinations. You can hallucinate in any of your senses. So we have 5 senses, our sense of touch, our sense of hearing, our sense of vision, our sense of taste. Um, all of those senses, and your most common ones are going to be your auditory hallucinations and your visual hallucinations. Some clients experience these false sense these things aren't really existing. Your auditory hallucinations is that they're going to be hearing voices. Usually the clients will kind of dart their eyes all over the place because if they're hearing things different and they're kind of looking around to see if they can see somebody saying what they're hearing. The most common are the auditory. And then visual hallucinations are things that they're seeing that really don't exist. These are the second most common. Initially, clients will perceive hallucinations as real experiences. Later on in the illness, they may recognize them as hallucinations. So, again, when you're assessing a patient, a client, if they have command hallucinations, that's when we start to get more concerned because these are going to be auditory hallucinations that are telling them to do something. Usually they're never good. Very rarely do people have positive auditory and visual hallucinations. They're usually negative things. Judgment and insight. Judgment refers to the ability to interpret one's environment and situations correctly. How we can test judgment sometimes is we ask somebody if you found a stamped address envelope on the ground, what would you do with it? Somebody with good judgment is going to say, I'm going to put it in the mailbox, right? It's already sealed, it's already addressed, it's got a stamp on it. I'll put it in the mailbox and it'll get to where it's got to go. When we talk about insight, this is the ability to understand the true nature of one's situation and the willingness to accept some personal responsibility for the situation. So, as you're talking with your client, you're going to start to get a sense of whether they truly have good insight or they don't have good insight. Those that have poor insight are going to continue to blame all of their events on people around them. They're not going to accept responsibility that the reason that they're in the facility is because they got drunk and they fault or they were obliterated, or there's no personal accountability in somebody with poor insight. Self-concept is the way that the client views themselves. We should all view ourselves with worth and dignity. Clients with poor self-concept are going to view themselves as worthless, and they're going to have negative beliefs about themselves. Roles in relationships are the way that they function within their community. Are they a parent? Are they a child? Do they have a job? How do they function in those roles? Um, and then your book has more categories of the family assessment in box 8.3. So, self-care considerations, these are important things that the client should be caring for themselves, right? They should be able to do a dietary recall and tell you what their eating habits are. If they don't, they could be manic, where they're not eating. They could be too depressed to eat. They could have an eating disorder. A lot of things affect the way somebody cares for themselves. So, getting a good idea of how they're handling the self care would be how severe their illness might be. Same thing with sleeping patterns. If a client tells you, I only sleep for 2 hours a night, that's a problem, right? We know that people need like 7 to 9 hours of sleep. So if you're only sleeping for two of those, that's an issue. Same thing if they're saying, I sleep 20 hours a day, that's an issue. um, Understanding how they care for their chronic health problems. Again, the more you get into this content, the more you'll realize that certain chronic health problems can create mental health illnesses. So, if they're not taking their thyroid medication, they might have a period of hypothyroidism, which might look like depression, or they might have hyperthyroidism, which can lead to anxiety and more manic type of behaviors. Non-compliance with their medication. We know that a lot of mental health patients are not compliant with their medication because as they take their medication, they start to feel better and they feel like they're cured. Then they stop taking their medications, their symptoms return again. They don't always instantly say, maybe I need to take my medication again. Sometimes clients with mental health do self medication with the use of drugs and alcohol. They have these unexplained feelings when they drink alcohol or they take their substances. It quiets the voices, it stops the anxiety, it sometimes helps them focus, but that self-medication obviously leads to other problems. So again, finding out all of these self-care is really important when you're doing your overall assessment with your clients. And you want to be very point blank when you're answering, when you're asking some of these questions. Do you use street drugs? Do you use marijuana? Do you use heroin? Do you use cocaine? Do you use opioids? Like, you need to be very articulate with this because sometimes just saying street drugs, they think, well, no, I didn't go on the street and buy anything. I took it out of my grandmother's medicine cabinet, right? So you need to be very specific to get the specific answers. So, which item would the nurse include when assessing a client's self concept? Would she include roles, support systems, body image, or abstract thinking? And the correct answer is C, body image. Assessment of the client's self concept includes information about the client's personal view of self, a description of physical self, and emotions. Your roles and your support systems are assessed when you're assessing the client's roles and relationships. Abstract thinking is addressed when assessing the client's sensorium and intellectual process. Data analysis. So after we get all of our assessment stuff, we have to, kind of go through it, all of it. We want to make sure that we will look at it globally. We don't want to look at it as individual little bits of information. And as we're going through it, certain patterns or themes should kind of start to arise, that will lead us to get a conclusion about the client's strengths, their needs, their problems, their risks. We want to assess, this is like an ongoing, it's a very dynamic process. Other elements that you can assess and analyze is our psychological testing, our psychiatric diagnoses, and our mental status examinations, which we're going to discuss all of these on the next few slides. So, your data analysis of your psychological tests, right? We have a different test that we can do. We can do intelligence tests. Intelligence tests are going to give you your client's cognitive abilities and their intellectual functioning. And then we can do personality tests, which kind of give us our self concepts, your impulse control, their major defenses. These can be objective, which is on page 138 in your book in the next slide, or projective, which is slide 116 and on page 138 as well. So your objective measures of personalities, these are going to reflect the client's personality in such areas as self-concept, impulse control, reality testing, major defenses. Personality tests may be objective. They're usually made up of true or false or multiple choice questions. These are going to give you an objective value. And within that value, it'll say, if they're this to this, they're this, if they're that to that, they're that. When we do our projective measures of personality, um, these are usually conducted as an interview, and it's going to be the client's response and how the person who is giving it analyzes it. So the Rorschach ink blots are something in this category. Usually with those ink blots, we expect the client to say certain things, um, and their response, depending on how it's analyzed, could change the narrative of the results of the test. So you could do Rorschach's with me and get one answer or one measurement. You could do Rorschach with somebody else and get it completely different. So these are a little bit more subjective. Dealing with your DSM-5, right? We know that the DSM-5 is what the provider is going to use. It's universally used for the diagnosis of psychiatric illnesses. The client's going to give their different types of what they're experiencing, and it's going to then give them a diagnosis. Um, When we do our mental status examination, this status examination is an essential component of the psychosocial assessment. It's usually done by a provider, such as a psychiatrist or a therapist. These examinations usually include items such as orientation to person, time, and place, day of the week, ability to interpret those proverbs, ability to perform calculations. That would be that counting back from 100 by sevens, memorization of short-term recall, which would be those 3 or 4 words, naming common objects in the environment, ability to follow multi-step commands, the ability to copy a simple drawing. are additional things that aren't in that nursing assessment. The fewer tasks the client completes accurately, the greater cognitive deficit they have, um, which is what this exam is trying to determine. So, true or false, personality test measures the person's cognitive abilities. The answer to this is false. Personality test reflects the client's personality in areas such as self concept, impulse control, reality testing, and major defenses. Intelligence tests evaluate the client's cognitive and intellectual functioning. Self-awareness issues, we need to gather all the information needed. Judgments are not part of the assessment, so you need to make sure that there's no judgments on your patients. We need to make sure that we're open, we're clear, we're direct when we're asking our questions. We want to make sure that we don't show any uncomfortableness when we're getting to certain topics. Again, the more we are self aware, the more we examine our own beliefs, the better we're going to serve our patients. And we want to make sure that our personal beliefs do not bleed into caring for our clients. And that is the end of this lecture with your key points, which you can find in the back of the chapter in the book. Thank you.